So thank you again, and I'm just going to turn it over to him. He's from New England Orthopedic Surgeon. So thank you for being here.
All right. Hey, everybody. Like she said, I'm Dr. Brothers. I'm a joint replacement surgeon at a NEOS, just right across the way, right next to Bay State. Been doing this for, including training, about 8-9 years now. I've been here in Massachusetts. Actually, I live in Connecticut, but working in Massachusetts for about 3 years now. Seems like I've gotten to know a lot of people, so I understand there's some people that either have met me before or have friends or family that have met me. So one thing about me, I love questions. So if in the middle of this presentation, if you have a question, if something pops into your head, raise your hand. We'll stop. We'll answer it. By all means, don't hesitate. Just raise your hand. If you raise your hand and I'm not seeing you, say something. Say I got a question, and we'll stop and we'll handle it. So, oh yeah, we'll wait for you to take a seat. There you go.
Hi, Doc.
How you been?
Remember me?
I do. How you been? You're walking nice.
2 weeks ago.
Yeah. So we're mainly talking about hip replacement today. I also do knee replacement, as many of you know, but I do a particular type of hip replacement called the anterior hip replacement, and that's oftentimes people have a lot of questions about that, so I figured I'd jump in on that and kind of show you guys exactly what it's like from my perspective. So a little about me, I'm an orthopedic surgeon. I was fellowship trained in what's called adult reconstruction. That's hip and knee replacement. Did my fellowship out in Salt Lake City in Utah. Up at the top right, that's my wife and me. This picture was actually from like 3 or 4 days ago. I was in Philadelphia for my sister's wedding, hence the tux. And then these are our cats. These pictures also from yesterday. She sends me pictures of our cats in the morning when I'm in the operating room. I usually text her, I say I love you, and send me sloopy pictures, and then next thing I know, a bunch of pictures come into my phone that I look at in between cases. I trained, hang on a second. There we go. This was my medical school at Jefferson University Hospital in Philadelphia. And then I went to St. Joseph's Medical Center in upstate New Jersey and was there for about 5 years. And then I ended up in University of Utah in Salt Lake City for 1 year, and that was fellowship training. That was a year of nonstop, nothing but hip and knee replacement. Now I'm at NEOS. I operate out of Bay State. I'm sure everybody here has heard of NEOS. They're a big orthopedic group, that big, old, ugly 3-story brick building that is going to be there till the end of time. We're going to be there until the end of time. And my focus is on hip and knee replacement. My practice started out about 50-50, about 50% hip replacement, 50% knee replacement. Then as people have kind of heard more and more about the anterior approach, it's definitely been a lot more hip replacement. So now I'd say it's probably about 70% hip replacement, maybe 30% knee replacement. We're just going to briefly kind of cover what we're going to talk today. We're going to talk about what arthritis is, what sort of treatments short of surgery there are, what sort of treatments that include surgery, and then kind of what's changed in the last decade or so about hip replacement that's really made it such a remarkable procedure. So arthritis is wear and tear on the joint. It's when the cartilage starts to break down and you no longer have a smooth articulating surface. Your joints want to be smooth because they're constantly in motion. And just like the tread wears down on your tires, over time, the cartilage wears down in your joint. Some people, it happens earlier than others. Personally, I ski a lot, and I have every family member that has had knee replacements, so I'm getting knee replacements. It's just a matter of time. Hopefully I can make it till I'm at least 60, but we'll see. But hips run well in our family. Never had a family member that needed a hip replacement, so hopefully I'll be able to get by without a hip sometime. This is a little picture kind of showing a healthy hip versus an arthritic hip. Does this have a laser pointer on it? Oh, no, it doesn't. It has a power button. There we go. So over here, I'll just point my finger. Over here in a healthy hip, you can see the cartilage is nice and smooth. You can see how the bone is well formed. There's no excess bone growth or anything. And then in an arthritic hip, you start getting bone spurs that grow from the edge of the bone. The articulation's no longer as smooth. And those of you who have had an arthritic hip, who have taken a look at an x-ray, especially if you have a normal hip on the other side, your other hip doesn't look at you, you don't have to be a doctor to read the x-ray. You just, that looks messed up, that looks pretty normal. It can be a quite obvious diagnosis. So here's a normal hip, and here's an arthritic hip. That's it, picture of an arthritic hip. Now that's a femoral head that we've removed in surgery. Again, you can see the loss of the cartilage in here. You can see how bumpy it is. You can imagine that's not creating a very smooth motion inside the joint, and that's what creates the pain. Over here, this is a normal hip. And you see how nice and white and glossy and smooth that cartilage is? So that's what we're born with, and then over time, as we use our joints, as we injure them, depending on certain risk factors we may have, the hip eventually becomes arthritic. If everyone lived to 150 years old, we'd all have arthritis in all of our joints. Basically, it's like a warranty. Sometimes the product lasts longer than others. Sometimes you get lucky, sometimes you don't. The good news is, when you do have arthritic hip, here is a perfect example, x-ray. So you can see on the right side, you can see this loss of the joint space. Over here on the left side, this is a normal hip, and this space in between the ball here and the socket here, this is where the cartilage is. Cartilage doesn't show up on x-ray. X-ray is really just looking at calcium, which happens to be in the bone, and the cartilage doesn't have any calcium in it. So we see cartilage on an x-ray as empty space. And in this arthritic hip over here, we can see that space has been obliterated. The bone, this is bone-on-bone arthritis. You can really see how the bones are touching each other. So as we said, there's lots of different risk factors that can be associated with arthritis. The biggest one is wear and tear. At the end of the day, you've used your hip for 60, 70, 80 years, and at a certain point, it's just done. If you injure your hip when you were young, if you had a really bad hip injury, it can predispose you to arthritis. You carry excess weight. The amount of force being applied to your hip every step of every day is increased, and that's putting more wear and tear on the hip. There are some genetic factors, like I mentioned, but all of my family members have knee replacements. We know that joint replacement kind of runs in families, so I'm not thinking of it as an if, it's just a when I end up getting my knees replaced. Symptoms of hip arthritis, the biggest symptom is pain in the groin. Now, when someone comes into my clinic and I say, where does it hurt? And they take their forefingers and they do this, they got a hip problem. People usually point, they say, it's kind of deep in there. Oftentimes people think that it started out as a groin pull, like, I think I pulled my muscle or something, but it just didn't get better and it slowly started to get worse. We also see pain on the lateral side of the hip out here. You get this accessory pain out here. And some people actually come in with no groin pain at all, only pain out here. You get an x-ray, they have an arthritic hip, you examine them, and the things that provoke hip pain cause that pain out there. So it's not everybody is exactly the same, but in general, if you're having pain in your groin, you should be thinking about your hip. A lot of people have difficulty getting shoes and socks on, have difficulty getting in and out of a car, and that has to do with this motion here, this rotation of the hip, getting into a car like that. One of the first things that you lose with hip arthritis is rotation. People with really severely arthritic hips, they can flex their hip straight up and down like this, but if I take them like this and I try and rotate their hip, hardly goes anywhere. And that makes it very difficult getting into a car, getting shoes and socks on. Oftentimes, back problems can mask themselves as hip problems, and vice versa. I'm constantly sending patients that come to me, they think they have a hip problem, and no, it's really your back. Send them to the back surgeon, and vice versa. I get a lot of patients that come to me with a severely arthritic hip. It's been arthritic for a decade, and they say, hey, everyone just thought it was my back. Thought it was my back. That's the thing. The two can really have similar effects. And that has to do with the nerves leaving the back. The nerves that leave the back, if those nerves get pinched, they can cause pain running right down into that hip region. And so the two can sometimes be a little misconstrued. If you feel like people have been telling you you have a back problem for your whole life, but you've been having this pain in the groin, it's probably worth checking on the hip. Like we talked about, location of pain is in the groin, and the biggest thing and the first thing that happens is restriction in range of motion, especially internal and external rotation in the hip. Another thing that can happen is a leg length inequality. Now, people don't oftentimes realize this until I tell them that their legs aren't the same length, but when a hip wears out, it tends to wear up. And so that whole leg shortens. And I've seen people walking in with kind of limping like this because one leg is shorter than the other. And like, yeah, it hurts, but I didn't realize that my leg was, you pull their legs out in front of them, one's sitting like that and one's like that. And it can be a pretty significant impact on your gait mechanics. We've already shown an x-ray of hip arthritis. So in terms of non-surgical management, so hip replacement is irreversible surgery. There's no going back once you've done it. Once we have cut the bone out of your body and put metal and plastic in its place, there's no undoing that. So it's really important that it's the right decision to be made when it is. In terms of things short of surgery, anti-inflammatories, injections, using a cane to offload the weight of your hip. Weight loss is always helpful, yes?
Do you want to talk more about injections, or was that it?
I don't have a whole lot more. I have another one more slide on here, but I'm happy to talk about them. So injections are, this is my professional opinion. I have partners that feel differently, and at the end of the day, it's non-surgical management. It's trying to get you along and keep you as functional as possible until you eventually need a hip replacement, because when you have hip arthritis, it, for the most part, is inevitable that you're going to need a hip replacement. It may not be in a month, it may not be for a few years, but at a certain point, that hip is going to continue to worsen. Injections for the hip. For knees, there's two types of injections. You have the steroid injection, the standard white shot that your primary care doctor will give you sometimes, the orthopedic surgeon will give you every time you see him. And they have gel injections, which is a lubricating sort of injection that's a little bit newer. It's been out for about 10, 15 years now. With the hip, gel injections are not approved. They don't really have any function in injecting the hip, so we stick with steroid injections. A steroid injection has two components to it. It's got lidocaine, which is a numbing medication, and it has the steroid, which is the point of the injection. It's a steroid injection. The lidocaine gives you some immediate relief. When I have a patient that their hip looks a little arthritic, it kind of feels arthritic, but I'm not sure. Maybe it's something else, and we really want to make sure we know. We'll do an injection, and I'll tell them, I really want you to pay attention to the first 12 hours or so, because that's when you're going to have that numbing medication in your hip, and if your pain is gone for those few hours after the injection, even if it doesn't last very long, even if it only lasts for a few hours, then we know that pain is coming from inside your hip joint. The lidocaine, like I said, gives you that immediate relief, and it's got that diagnostic value. When that pain goes away from shooting a numbing medication into the hip joint, we know it's coming from the hip. The steroid can take a couple days to kick in. So oftentimes people feel great after an injection, and then the next day they hurt again. And I have to caution them not to conclude that the injection only worked for a day, because the steroid hasn't had enough time to work yet, and oftentimes it could take a couple days before that pain starts easing off again. With injections, I tend to use them more when someone has milder arthritis and milder symptoms, because in that setting, it can last for some significant time. I've had patients get by for a year with little pain after an injection. But once you start getting to that bone-on-bone arthritis and you've got that mechanical grinding in your hip, it doesn't tend to work that well. And the pitfall with an injection is a steroid is an immune suppressant. And we want your immune system working full strength when we do a hip replacement on you. So if we do an injection, we have to wait 3 months to do a hip replacement. So if you come in and you're dying and it's been killing me forever, but you want to try an injection first, Well, if that injection only works for a day and the steroid doesn't work, now you have to wait 3 months for a hip replacement. So oftentimes when someone comes in with really severe arthritis and they're asking about an injection, I'll tell them it's probably not going to work. If you need something done, it should probably just be a hip replacement. Does that answer your question?
And is the steroid cortisone, or is that something different?
Cortisone is like the prototype steroid. Nowadays we use one called Kenalog, which is like cortisone, which is a very slightly different chain on the end, and it's just a little bit more gentle to the bone. But yeah, basically that's the colloquial term used for a cortisone injection. So in terms of anti-inflammatories, we have over-the-counter options, Aleve, Advil, and then we have prescription options like Celebrex, meloxicam. You see meloxicam all the way over on the right. That's a once-a-day medication. That's oftentimes where we'll start when someone comes in. They haven't really tried any non-surgical options yet, but they've got really severe arthritis, and maybe they're not quite ready to jump right into surgery. Prescribe them a long-acting anti-inflammatory, and that can oftentimes carry someone along quite a ways. Now, the thing about anti-inflammatories is your kidneys don't love them. You can't stay on them for your entire life. Eventually, it will start causing kidney damage. So usually when we're prescribing someone an anti-inflammatory, it's sort of a stopgap. We're saying, like, well, we're going to try this for maybe 6 months, and then we'll see how the symptoms go. But look, we're heading for a hip replacement. We're heading for a knee replacement. Tylenol, on the other hand, totally fine. Was that a question?
Well, no, I do, because I just about live on fish oil
Yes.
to walk.
Yes.
And I just wondered, it's not on the list, but when you finish with that, would you explain how you feel about, I take about 6,000 milligrams a day.
Uh-huh.
That keeps me going.
Yeah.
I'm 86 years old.
So there's a lot of research on fish oil in terms of overall health. It has incredible amounts of omega fatty acids, which are really good for your brain, and we believe good for your joints. But we don't have a whole lot of data on the immediate effect where, you have arthritis, let's give you fish oil and see if that makes the arthritis better. Not a whole lot of data on that. So I do think it's a really good habit to be in. I take a fish oil pill myself, but I don't think it's particularly related to like the acute management of a painful arthritic joint.
It takes about 6 months for you to notice it in your body. I've been on it for years.
Yeah.
I just wondered how you felt about it.
Yeah. Yes.
I have a question about meloxicam, and I'm not sure whether this is the time or the place.
Anytime.
Okay, all right. After I had COVID, I developed GI issues,
Yes.
and the acid reflux and NEOS. And I was on meloxicam, and the GI doctor recommended that I stop
Yes.
taking it. But it really was helping with the arthritis.
Yes.
So I have substituted arthritis Tylenol.
Mm-hmm.
And it's taking the edge off, but not as much as the meloxicam.
Right. So Tylenol doesn't affect the stomach at all.
Yeah.
Tylenol is a totally safe drug. The thing about Tylenol is you can't overdose on it. But in order to overdose on Tylenol, you need to take a lot of it, well above the maximum daily dose. Anti-inflammatories are the ones that have these effects that build up over time, like kidney dysfunction and upset stomach. So moving from Celebrex or moving from meloxicam to Tylenol is a perfect move for that problem with having an issue with the stomach. Another one, if you find that the Tylenol isn't quite enough, though, this medication here, Celebrex, this is a second generation anti-inflammatory. It actually bypasses the stomach. It still does have that long-term effect on your kidneys, so it's not something you can take all the rest of your life. But if you're taking a regular anti-inflammatory and you're having stomach issues, Celebrex is something to try because it tends to not have those same effects.
So what is the recommended dose of Celebrex?
It's either 200 milligrams a day, like once a day, or 100 milligrams twice a day. Mm.
Okay. Yeah.
Yeah, of course. Let's move on. Medications to avoid. Narcotics. It is really important, especially for a treatable condition like arthritis. You have an arthritic hip, you can get a hip replacement to eradicate that pain. But every once in a while, we have someone that comes in and they've been prescribed oxycodone or Percocet, and they've been on that now for a year for their arthritic hip. And number one, I would just get the hip fixed. But number two, now they have developed some tolerance to that, and now they have a dependence to it, and they require higher levels of pain medications after surgery, and their baseline pain threshold is elevated. So things that maybe would just be an ache are now more of a nuisance and more of a significant pain. So in general, we recommend against chronic narcotics. We do prescribe narcotics after surgery. You definitely need them after a knee replacement. Hip replacement, más o menos. Some people get by with just taking Tylenol. Most people, if they take the narcotics, it's just for a couple days for that kind of the acute pain right after surgery. And then usually within a few days, they're saying, I don't really need this, and just leave it on the shelf. Yes?
Tramadol.
Tramadol is sort of like the in-between step. So tramadol is a controlled substance. It is not a narcotic, but it works on the narcotic system in your brain. And we use that. That one is more reasonable for taking before surgery. So people that come in that are on chronic tramadol for pain control, they don't tend to have those same effects of tolerance building, dependence building, increased pain. We also use that after surgery as well. And we kind of encourage patients to use that to substitute out narcotics. Maybe your pain, yeah, I got pain and I need to take something, but it's not so bad that I need an oxycodone, so I'll take a tramadol instead.
When I had ankle surgery with Dr. Byrne, they tried to put me on oxycodone, and I said no.
Yeah.
And so
Yeah.
I said no. They said, well, the next choice would be tramadol. And fine.
Yeah.
Yeah.
It's some people, especially some people like over the age of 65, 70, can have a reaction to tramadol where it kind of makes you loopy and sort of you're seeing stuff and hearing voices and stuff. I have seen that from time to time. So that is something to be aware with it. That can also happen with narcotics though. But in general, yeah, it tends to be sort of that nice like middle road pain medication where it has some of those benefits of a narcotic pain medication, but not quite so much of the downsides. Glucosamine, chondroitin sulfate, those or supplements that you see that are available in any vitamin store. The data on them is fairly limited. I have plenty of patients who come in, they swear by it, say, I started taking it, my knees felt great ever since. And if that's the case for you, perfect. Go ahead and take it. It's not gonna hurt you. That being said, don't run out and go buy a lifelong supply of it, expecting it to work, because your mileage may vary. Some people say, nah, I tried it, didn't do anything. We talked about injections a little bit before. So for the hip, we use steroid injections. Gel shots are not an option for the hip. They're not approved. And we talked a little bit about that diagnostic and therapeutic benefit. If we're not totally sure if it's the hip, you do an injection, it gives you the answer. Either it is, because the pain got better, or it's not. And if the pain gets better and it stays better for a while, mazel tov. And if it doesn't, if it gets better and then it comes back, we have a solution for that. Weight reduction is definitely something, if you have mild arthritis or moderate arthritis and you're carrying a little bit of extra weight, it's important to understand that the joints in your body feel multiple times your body weight every single day at multiple points throughout the day. There's something called joint reactive force, which is basically the force that's being applied in your hip to keep that hip in the socket. And when we measure that, when running, the joint feels up to 10 times your body weight, up to 5 times your body weight when you're walking. Just standing on one leg, the joint's feeling 3 times your body weight. And that's because of the muscles holding the joint into place, because of the lever arm, because the center of rotation is here, but it's the rest of the weight is being borne out here. And that's why weight loss is really effective. Now, again, if you have a hip that is done, that is bone on bone and just grinding away, yeah, losing a couple pounds is probably not going to help that. But if you're in this kind of middling period where you're developing arthritis and it's hurting, but you get the x-ray and it's kind of mild and the symptoms are sort of in between, if you're carrying some extra pounds, losing as many as 5 or as few as 5 to 10 pounds can mean a difference of 50 pounds being felt across your hip. And that's every single step, every single day. Now, weight reduction is not easy with an arthritic hip. You can't run with an arthritic hip. You can diet, and generally dieting is where weight loss is mainly achieved. There's lots of people out there that call themselves nutritionists. It's not a protected term. Anyone can, my cousin can call him, he's a computer engineer, but he could say, I'm a nutritionist and set up shop and start taking clients. If you're interested in dieting and weight loss, the thing to look for is a dietitian. That is a protected term. That person is a professional that has gone through dietary training. They've defended a thesis. That is essentially a doctor of dieting. Just food for thought. Activity modifications. In general, we want people to be as active as they possibly can. With an arthritic joint, someone comes in, they've got an arthritic knee or an arthritic hip, but they're not ready for surgery yet, and they ask me, what can I do? Everything. And you should. We see patients that come in that they're the kind of people that don't let pain stop them. Terrible arthritis. Like, how are you even walking? But they just don't let me stop. Just keep going. And they tend to not have as much pain versus people that let pain stop them and it hurts today, so I'm going to sit down, I'm not going to do anything. That tends to beget more pain. So in general, like trying to remain active, even though this is a condition of wear and tear, it sounds counterintuitive, but remaining as active as you can, line dancing out there, that will prolong the life of your hip, your knee, even in a state of arthritis. That will make the pain get worse slower. It will give you more time with it. Stem cells, PRP, every once in a while I get asked about these sorts of things where they take something from your body and put it in a centrifuge and inject it back in. There's no good evidence supporting it. Also, coincidentally, they're not covered by insurance, so you have to pay out of pocket for it. Whenever someone asks me about them, I tell them emphatically, I recommend against it. Maybe 50, 60, 70 years from now, we'll have the technology to regrow our cartilage with stem cells, but it's not coming anytime soon.
You know.
I know, right? My job is safe for at least, yeah. So when non-operative treatment fails, it's time for hip replacement. Here's some bilateral hip replacements. And this is what a hip replacement is. So I don't have the pointer, so I'm pointing it with my finger. This is the native socket, the bone of the native socket. And inside the socket, we've put a cup of metal. And inside that metal cup goes a plastic liner. We don't want metal on metal. They did try that for a little bit, and it didn't work out too well. And so the plastic liner, the plastic part that goes inside the cup, that is the part that's actually articulating. The stem goes down inside the bone of the femur, and the ball we call the head. The ball goes on the stem. So it's 4 parts: cup, liner, ball, and stem. And that's creating the new hip joint right in here. That's a perfect, so we can see right here the cup, the plastic liner, the head, and the stem. And many of these components are press fit into the bone. They actually have a porous surface that mimics the shape of bone on a molecular level. Turns out bone isn't that smart. We prepare the bone and implant the implants, and the bone thinks it's fractured. And it finds this metal that looks just like bone right up next to it, and it says, it must be my other half. And it tries to heal what it thinks is a fracture, and it actually grows into the metal and unites the metal with your body. Some people have very, very weak bone, and when that's the case, it's not the best idea to try and press fit one of these implants in because you can break the bone. So there are definitely some patients with severe osteoporosis, and in those patients, we use what's called a cemented stem, which is a smooth, polished stem, and we fill the femoral canal with a type of bone cement. The stem goes in the cement cures, and that's much more resistant to fracture. One thing we worry about, yes?
How would you know ahead of time that that person might need the cement and the other with the osteoporosis?
So the question, and I should start repeating questions because I realize you guys probably can't hear. The question is, how would you know ahead of time if someone is going to need a cemented stem versus a press fit stem if they have osteoporosis? And in general, you can tell from the x-ray. Surgeons have enough pattern recognition from seeing an x-ray and doing a surgery, seeing an x-ray, doing a surgery, that like you kind of pick up on these cues and you say, this patient, and I'll tell a patient in advance, I'll say, look, I think we may want to use a cemented stem on you. I'll describe that to them. And then oftentimes it's an intraoperative decision. You sometimes get fooled. I've had patients where I said, we've got to cement. It's going to be very weak bone. You get in there, that bone's really strong, surprisingly strong. That does happen. So a lot of times it's an intraoperative decision. Sometimes we'll go in expecting to use a press fit implant. Turns out the bone's not quite as hard as we thought. It's fairly soft, and we'll convert to a cemented implant for that purpose. This is the procedure in a nutshell. First thing we have to do is remove the femoral head and the femoral neck. That's this right here. We then forget about the femur for a moment. We're going straight to the cup, and we ream the socket. A reamer looks like a cheese grater, except it's half of a globe. And the idea of that is to bite into the bone, to get down into that bleeding cancellous inner bone that's going to think it's fractured and then grow into the metal of the cup. We impact the cup and the liner into the bone. Just like we have to prepare the socket for the cup, we have to prepare the femur for the stem. And that can be done depending on the system with either what's called, reaming or broaching. The femoral component goes in. The head, here we call it a ball, we call it the head. The head goes on the stem. And once all the components are in, we pop the hip back in the socket, close up, and about 3-4 hours later, you're up and walking.
Yeah, okay.
Exactly. Yes. Yes.
You know, when they cement, but they're doing these earlier and earlier. They used to try to postpone it because
Yes.
it had to be replaced. How is that going to happen? If you're cementing it in, what do they do then to replace a knee replacement?
To redo a knee replacement? Yeah, so
Because they were doing it, because I think those are 10-year lifespan or 15 years, and now they seem to be doing it for younger and younger people.
right. Oh, I'm sorry, I hit the button again. So the question was about how do you redo a knee replacement when a knee replacement is cemented into the bone? And the underlying idea of that question is the fact that for a long time, knee replacements were only supposedly lasting 10, maybe 15 years. Nowadays, we're doing knee replacements on younger people, although we still try to wait as long as we can. The answer as to the longevity of a joint replacement, in 2005, we developed a new type of plastic. And the previous generation of plastic was lasting about 15 years. The new plastic wears at 1/10 of that rate. And so now we don't know how long a knee or hip replacement will last. And the reason for that is because people keep dying before their knee or hip replacements wear out. 1/10 of the rate of wear of a joint replacement that was lasting 15 years, 150 years. So we think the idea of a joint replacement wearing out is what we call of historical significance, important to know about, but not really relevant in modern day practice. When it comes to redoing a knee replacement or even a hip replacement, the answer is simple. You have to cut out the components, and that means losing more bone. And that's why we're oftentimes very hesitant to do revision surgery, especially if there's not a clear and concise problem. If someone comes in with a knee replacement that they just don't like, it feels fine, it looks fine, but it hurts and they want it redone, it's usually not a good idea to redo it because you're sacrificing valuable bone. They're losing bone stock in the process. And if you don't have a diagnosis of what the problem is, you're probably not fixing anything. So in that situation, those patients oftentimes come back out, they have a revision, and their symptoms aren't any better. It's just they're one step further down the path. As part of why it's so important to get it right the first time, you want to avoid a revision whenever possible. Getting back to the approaches, what haven't been mentioned so far is approaches to the hip. So there's various aspects that have made hip replacement sort of a new game in the last 10, 15 years. Modern approaches, modern protocols about rehabilitation and exercise, modern pain control regimens, and then also new technology. So this is an old school hip replacement. Some of you may have known someone that had a hip replacement done in the 1970s, 1980s. Yep, 2000. Big, giant incision. And there was a lot of blood loss with these hip replacements. People oftentimes had to have transfusions after surgery. Oftentimes they would have restricted weight bearing for a period of time. And the hospital stay was very long. We used to admit people to the hospital a day before their surgery just to look at them. And then we do surgery and keep them in for another week or so before letting them go home. All of the advancements that kind of have occurred over the last 10, 15 years have sort of transformed that from a massive ordeal to what is essentially a same-day surgery. The traditional approach, or the posterior approach, is what most surgeons do. And that approach goes right through the gluteus maximus muscle. This muscle here, it's the big muscle in your butt. That's the muscle you're using to get out of a chair. That's the muscle you're using to walk with. And it is the biggest muscle in your body. Now, with this approach, they split the muscle in line with the fibers. And I do this approach too, sometimes on complex primary hip replacements. And for many revisions that I do, I go through the posterior approach. It's got some significant benefits. It is an extensile approach. You can see a lot more. If you need to get to more of the bone, more of the hip, it's much easier to do that through a posterior approach. The problem with it is cutting through the structures of the back of the hip in order to get into the hip joint. With the posterior approach, there's a risk of dislocation, and that's when the hip pops out of the socket. I think this right here shows cutting off and cutting out the posterior structures, tagging them, and then we tie them back into the bone afterwards. This is one of the potential complications, is a dislocation. This is where the hip has popped out of the socket. What would cause the hip to pop out of the socket? Well, you have to pop the hip out of the socket during surgery, no matter which way you're going, whether it's from the front or from the back. And so after surgery, if the hip is going to pop out of the socket, it's probably going to pop out of the socket the same way you did during surgery. It's the route that you violated. It's the weak pathway for the hip to get out. And so with the posterior approach, the way we access the hip is by flexion of the hip and internal rotation, and the hip goes out through the back. So those are the movements that would put you at risk for a dislocation after surgery. The problem with that is we live our lives in hip flexion. Every single one of you are flexing your hips right now just by sitting. You bend over to pick something up, you're flexing your hip. You scratch the side of your ankle, you're flexing your hip. We do a lot of hip flexion activities. With the anterior approach, we're going in from the opposite side. We're coming in from the front, and so we're gaining access to the hip by externally rotating the hip and extending it behind the body. And that is the way an anterior hip replacement would dislocate if it dislocated. But the nice thing is nobody really does that. No one's doing this as part of their daily activities. And so with the anterior approach, we say no precautions, no restrictions. Walk how you want, sit how you want, sleep how you want, do what you want.
Up and down stairs too?
You're not allowed to leave the hospital until you've shown them you can go up and down stairs. One of the things that has an effect on the risk of dislocation is component positioning. You really want the components to be positioned in the right orientation and position. You have the goal position here. There's specific metrics that you want on your abduction and your anteversion, which are physical descriptions of how the cup is placed in the body relative to the midline. And with the anterior approach, because we're using X-ray during surgery, every cup that goes in goes, the way I describe to patients, like, I don't really need your post-op X-ray because I've been shooting your post-op X-rays the whole case. We impact the cup under live fluoroscopy. We impact the cup in, we take an X-ray, and we say, that's about 2 degrees too abducted. Back it out, adjust it a little bit, take an X-ray. That's perfect. So with the anterior approach, when you have live X-ray to do your surgery with, every cup is going to go in exactly as you want it to be, and you're going to avoid issues with malpositioned components. Another thing that can happen after hip replacement surgery is leg length inequality. So we're measuring that. We're looking here at this bump here. This is the lesser trochanter. And we're comparing this line here, which is right at the bottom of the pelvis. And we can see this bump is way too high. This bump needs to be down here. This leg is longer than this one. That's another thing that is related to stability. In my posterior hip replacements, on my revisions, when I revise someone and have to put in another hip replacement, I tell them in advance, I'm going to have to lengthen your leg. Because lengthening that leg increases the tension in the soft tissues, the joint reactive force that we talked about before, that force holding the hip into the socket. When you lengthen the leg, that force is increased and it helps the hip keep from popping out. With the anterior approach, having X-ray available, knowing that the hip is very inherently stable and I don't really have to worry so much about the risk of dislocation, you can be a lot more judicious about lining up the leg lengths and making sure that the legs come out the same length. So this is the anterior approach. We talked about the posterior approach before, going through the gluteus maximus muscle. With the anterior approach, we're going right in through here. This muscle here is called the tensor fascia lata. You don't have to remember that. It doesn't have terribly much function. I could go in and cut your tensor fascia lata and just leave it hanging in the breeze, close you up, and within 2 or 3 weeks, you'd be walking around and it doesn't feel any different. We're going around that muscle. We're opening up the fascia sheath. We're pulling it out to the side. We're going past it, and just beneath that is this interval between 2 series of muscles. So you move this to the side, you move that to the side, and you're looking right at the hip joint without cutting any muscle at all. No damage to that gluteus maximus muscle. That means right after surgery, this is working totally. You can get up out of the chair, get walking quicker. People tend to get rid of their walker sooner. Are you in the cane now? There we go. Oh, yeah. So 2 weeks out from a hip replacement on a cane. I do younger patients. I've had younger patients. Actually, I have a video of someone who I think is in his like mid-60s who is walking without the use of a walker right after surgery, and I'll show you that in a little bit. There's a lower risk of dislocation with the anterior approach. Because we're not violating those posterior stabilizing structures, you don't have any of those posterior hip precautions. You can flex your hip as much as you want it. You can internally rotate it. You can bend down to pick things up off the ground if you want to. We talked about X-ray. We're using X-ray, and that means we can position the components perfectly. Usually, when I put the cup in, I'm doing it piecemeal, bit by bit by bit. And by the time it's fully seated, it's exactly how I want it to be. But every week, at least once a week, I do that. I get the cup seated, and I look at the X-ray a little more closely, and I say, it could be a little bit better. And we back that cup right out and put it back in a little bit better. Having that live feedback really allows you to make it perfect the first time. There's no, it looks pretty good. We're actually measuring it, and we know exactly what the indices that we're aiming for are and what we're going to achieve. This is a picture, an intraoperative picture of a cup in the socket. This cup is nicely abducted, about 45 degrees. You can see this ellipse here. That's the face of the cup, and the face of the cup is supposed to be pointing a little bit forward. That's anteversion. So this is what we like to see. Here's another intraoperative shot showing the cup, a trial head, and a broach in the bone. So we've finished putting the cup in, and now we're preparing for the femur, and we're double checking to make sure that things are lining up as we want before we put the final implants in. We talked about leg length inequality. I showed you that before, and you can see on this one, in this case, this patient has a left leg that's significantly longer than the right. And doing a hip replacement and using live x-ray, you can make sure to match up their leg lengths as perfectly as possible. I tell my patients, usually within about 2 millimeters. And I care about that 2 millimeters. I'll really look at that 2 millimeters and really kind of, and I'll ask my PA, should we go up one? Should we go now? You like this one? And they'll say, no, it's fine. I'll go, now let's go up one. Because especially with the anterior approach, when you have all of the tissue still left attached to your hip, you can really feel where your hip is in space. You're a little bit more sensitive to whether or not that leg is long. So it's really important to make sure to match them up as perfectly as possible. This is templating. So how do I know what I'm going to put in you? We could just figure it out as we went in, but it's good to have a plan going in, especially with a deformity case, especially when you're dealing with a leg length discrepancy and you really want to know what you're expecting to see when you get in there. So this is a picture of a template. This is a hip replacement has already been done. And you can see here, I've sized the cup, I've sized the stem, I've positioned them exactly where I want them. And then there's the after. You can go back again, and you can see how well we're matching that template that we put together. I think I have another example here. Yep. So here's a template of a hip, and this patient is starting out with pretty similar leg lengths. This bump here and this bump here are pretty well aligned, so I want to make sure I'm not over lengthening their leg. And then here is the post-op. And it's really important in deformity cases. This is a patient that had something called Perthes disease. This patient had it when he was anywhere between 12 and 15 years old. It was a condition that affected the hip and caused the hip to grow in an abnormal shape and position. You can see how short this leg is. Look at his lesser trochanter all the way up here compared to this side. Very little room to work here. I have to make a femoral neck cut. I have about 2 to 3 millimeters of space to fit my saw in to cut it at the right spot in order to get this hip where I want it to be. So here's our template, and we're templating the other side so that we know what the normal anatomy would look like. If I was doing a hip replacement on a normal anatomy side, what would I be expecting to put in? And how does that compare to what I'm going to find on this side with this deformity that has occurred over the course of decades? And there's afterwards. And you can see all of a sudden this hip that was all short and scrunched up, now that looks pretty close to the other side. Here we go. So I got videos. This is a post-op day 0. Now, I double-checked multiple times, and the videos were working, and they were working, and they were working, and then I got here, and they're not working, which is classic for PowerPoint presentations. So I had a backup, and I have them right here.
All right. So, John, so
this is
about 4 hours after your hip replacement. You want to show me, just get up out of your chair.
And that's the gluteus muscle working.
Yeah. There you go.
Now he's 4 hours after surgery. You know, he's not strutting around like he was born, you know, but you can see the function of his muscles as he's walking around. He's able to hold his weight. He's stable.
Yeah, exactly. You'll find yourself walking pretty normally pretty soon. It'll be sore tomorrow and a little bit more the next day, but exactly. Yeah, that's fine. Yeah, doing great. All right, man.
So, John?
The last thing he says, I think I'll get out of here. This is post-op week 6. This is a little bit of a shorter video because they move so fast you can't keep the camera on too long. Taking some time to load for a 6-minute or 6-second video. There we go.
What are you, 6 weeks? There we go.
And that's, I tell my patients, 99% of patients, 6 weeks after surgery, they're walking into clinic. You can't tell they had surgery. Just by looking at them walk in, they're walking with a normal gait. Yeah, still it'll ache every once in a while. I bend over and it's a little bit of a twinge in here. But in general, you see people that started out limping, hardly able to walk, 6 weeks later, back to normal. It really is a remarkable. That's hip replacement. Knee replacement, not quite so much. Knee replacement's definitely a longer recovery. But in the end, knee replacement is also a similar result, just takes longer. Yes?
On the hip that was deformed.
I'll get you in a second. What's,
On the hip that was deformed.
Yes.
You lengthened it to match his other leg.
yes.
The muscle and the nerve, all that was already the right length, or would it stretch on?
They stretch. So after that surgery, the hip is a little bit tight. The range of motion is a little bit tight because of that stretching of the muscles. But muscles are designed to stretch. The way that they work is by stretching and extending and flexing and contracting. And over about 6 months or so, the muscle actually lengthens a little bit, and then that range of motion gets better. Yes. Wait, you were next.
I was gonna say, was I able to do that after 6, 7 hours? Because I was walking,
Yeah.
but now, the only thing that's tough on me right now is the muscle is stretching like you just said.
Yeah.
And I wanna do something, but I can feel the muscle stretching.
Yeah.
Other than that,
And that's okay. Like, go ahead and let that muscle stretch. You're not going to hurt it. I think you'd be able to do that at 6 weeks. 4 hours after surgery, I don't know if you're quite at that level then, but everyone's mileage is different. Some people bounce back a little bit quicker.
all I know is I've been doing stretching exercises here at the senior center for the last 1.5 to 2 years.
Yeah.
And I knew I had a hip replacement coming. And I've been doing the stretching for the arthritis, and I think it's helped me go through this.
Yeah.
So I wasn't so bad.
Yeah. No, I agree. There's a lot of patients that I tell, like, the most important thing for you to do between now and the time of surgery is stretch it. Get those muscles stretching, try and get some motion back in that hip. I tell people that partially because it makes my life easier in surgery. Someone that's been stretching their hip, it's a little bit easier to get exposure. But I think it also helps a lot on the recovery on the post side. You had a question?
I have a question. Are they still using titanium? Is that what it is?
Yes.
If you don't mind me saying, my nephew is 50. He played hockey from the time he was 3, so his hip was messed up really bad.
Yeah.
And he also coaches hockey for his kids. So he had a hip replacement somewhere in Boston. They put ceramic.
Yes.
Have you heard of that
Yes. So,
technique?
yeah, if I bounce back to, let me go back to a different slide. So there's different bearing options. You're right almost in everything that you said. So the stem is titanium, the cup is titanium. This ball here, the head, that actually is ceramic. and that's why it's pink like that. 10 years ago, 15 years ago, we were using metal heads, and it was a cobalt chromium alloy. And they started to have some problems with reacting with the metal in the stem, and so we switched to these ceramic heads that have less wear and friction inside the joint. And there are other options for bearing service, one of which is ceramic on ceramic, where instead of a plastic liner, it's a ceramic liner made of the same material as this. That was designed to try and solve the issue of hips wearing out, because a ceramic on ceramic bearing should last millennia. Yeah. But as they were developing that, they also developed this new plastic which kind of solved that problem. And the ceramic on ceramic bearing does have some unique problems of its own, one of which is it can squeak. So, and you can find videos, if you go on YouTube and search squeaking hip replacement, you'll see someone go, beep, 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 and every time they, so nowadays we consider this ceramic on, we call this poly, it's polyethylene. So ceramic on poly is what we consider the gold standard nowadays.
So you don't squeak.
No squeaking on that one, correct?
I call my nephew tonight.
Ask him if it squeaks.
Dennis, are you squeaking?
Yeah. Now, if all you know is that he has ceramic in it, it may very well be that he has just gold standard ceramic on poly.
I asked him because I'm curious.
Yeah.
But he did a lot of research on it, and evidently there's not a lot of doctors that were doing it, a few years ago.
So it may actually be that ceramic on ceramic bearing.
I think it
And
is.
in which case, if it doesn't squeak, he's got nothing to worry about. They'll last in the rest of his life.
So I'll just text him, Dennis, are you squeaking? Yeah. He's going to say, Auntie, you lost it.
Question there.
Question, you said that with knee surgery, it's longer recovery.
Yes.
Like, how long?
So 6 weeks after a hip replacement, patients have basically no pain. And they're back to more or less full function. 6 weeks after a knee replacement, people are saying, I'm turning the corner.
Okay.
They are getting there. They're starting to get better than they were before surgery, but it is a long road. Yeah, usually people, I'm sure you guys have all met someone who has a knee replacement and said, I should have done it years ago. Best thing I ever did in my life. They're not saying that at 6 weeks. They're saying that at around 3 months after surgery. Usually at that point, it's like, it's really good. They're moving really well. They feel kind of back to normal, but it's definitely a longer recovery.
In the case of knee surgery and shoulder surgery, do they recommend physical therapy before those surgeries?
Yeah, it depends. If you have a restriction in range of motion or if you have a lot of muscle weakness, then physical therapy before surgery is probably a good idea. But it's not necessarily the hard and fast rule for everybody.
Okay, all right.
Mm-hmm. I think you had a question? Did someone else have a question? Yes.
Can you go after you have your hip replaced and you've gotten past the 6 weeks? Are you able to walk as much as you want, swim, bike, do all the things, or is there any restrictions?
Zero restrictions.
Oh, okay.
I'll tell people in clinic, I'll say, go skiing, go skydiving, go sumo wrestling, whatever you want. Yeah.
Oh, okay. Thank you.
Yeah. Yes.
I'm sorry, how long after that a hip replacement are you really able to, resume regular activity?
Yeah, so basically as soon as you feel ready. It's just a matter of titrating. So the way I describe it to people, as you get through the recovery, you will naturally feel better and better every day. The better you feel, the more you're going to do. You will overdo it. Overdoing it doesn't feel like anything in that moment. You're feeling great. You're like you did a chore and you went for a walk, and I can go grab groceries, but the next day you wake up and you're like, oh, that's a little more sore. That is your hip talking to you and saying, hey, yesterday was too much. I'm angry now. Give me a break. And it's just a series of titrating and increasing your level of activity until you feel like, yep, no, that was a little bit too much yesterday, and taking a little rest. Generally, by 6 weeks, especially for like younger patients in their like 60s, early 60s, mid 60s, usually by 6 weeks, they are kind of back to full level of activity. Technically, it takes 3 months for the bone to completely finish growing into the metal. There are some surgeons that will say, man, you probably shouldn't run until that 3-month mark, but that's not my opinion, personally. I tell people you can run when you feel ready. All right. Let me get back to where we were at. We did the videos. Wrong presentation. Pain control has changed dramatically. We used to just give you a whole bunch of morphine. Morphine. Nowadays, we're using what we call a multimodal regimen where we're using Tylenol around the clock, anti-inflammatories around the clock. Sometimes we'll use nerve medications like Lyrica. We're using tramadol like we discussed. All of these things kind of in conjunction together, and all of these different medications work in different parts of the pain system. So when you use them in conjunction together, you tend to not need quite as much of all of them. We start off with a spinal anesthesia. Every once in a while we have to do general anesthesia, but for most of our patients we do a spinal, which means you get a shot in the back, you go numb from the waist down, and yes, you're still sleeping for surgery. You don't have to be. I have had a patient that said, I wanted to be awake for the whole thing. I said, no problem. We were chatting the whole time. Generally, people don't want to do that, though. And so they're giving you enough medication to make you take a nap without knocking you out so much that you have to have a tube down your throat. So you're breathing on your own. And the nice thing about the spinal is you wake up after surgery and you don't have any pain because you still got a spinal. And that spinal slowly wears off. You can slowly start to feel the tips of your toes, and then over the next 2 to 3 hours, the sensation comes back, and you can start to feel whatever pain you're having. You have time to kind of gauge it and react to it. Versus general anesthesia, where we put you to sleep with gas, we wake you up, and in that moment, you're feeling everything I just did to you. A little bit of a rougher ride. I inject a lot of numbing medication around the surgery site. That tries to bypass a lot of the 24 hours of the ouch, ouch, sharp pain. We've all cut ourselves before. You know, when you cut yourself, it hurts bad for about 12 to 24 hours, and then it's sort of more of a dull, throbbing achiness. Same thing with surgery on a much bigger level. So injecting local anesthetic throughout the surgical site, during and at the end of surgery, helps try and bypass some of that really sharp pain to get you off into the dull, throbbing sort of pain. Like we talked about, we use Tylenol, Celebrex, Tramadol. Those are more or less around the clock. And then narcotics are for breakthrough pain. If you don't need the oxycodone, don't take the oxycodone. With protocols like this, we've found that there's a significant decrease in the amount of narcotics that are being used by patients. The amount of narcotics you take into your body throughout the whole course of your recovery is significantly less. We find that patients tend to have higher satisfaction rates, and they tend to have shorter lengths of stay. Remember, before we were keeping people in the hospital for almost a week after surgery, and now, at least at NEOS, about 33% of our patients are going home same day. Minimizing blood loss. A lot of people have known someone that's had to have a transfusion in the past. And transfusions are not ideal. You can have reactions to them, but even just the act of getting a transfusion can increase your risk of getting an infection in your joint replacement. And so we've discovered this medication in the last 20 years called tranexamic acid. And it's a clot stabilizer. It basically reduces the amount of bleeding you have both during surgery and in surgery. It does not increase the risk of a blood clot, but it reduces that bleeding during surgery. And so once we started using tranexamic acid on our patients, our transfusion rate dropped to almost nil, from about 10, 15% to pretty much zero, with the exception of a really big revision of massive, giant surgery. That patient's probably still going to need a transfusion. Yes?
Are there any side effects from that?
So the only real thing of concern is that it can lower the seizure threshold. So if you have epilepsy, if you have an undiagnosed brain tumor, that's been my personal experience before. not myself, but like with a patient, it can cause, getting tranexamic acid can cause a seizure.
I see. But for somebody without that problem,
No reason not to. Correct. Yes. Yes.
Is the East Long Meadow office the same as the one?
Yeah.
Oh.
Yeah, it's just a satellite office. So our mothership is Bernie, but we've got a satellite office on Benton and East Longmeadow.
Yeah.
We've got an office up in Northampton now. I don't think we're in Westfield yet, but we should expand out there.
If you're having x-rays, do you have to like be off calcium or anything like that?
Nah.
Not
Not at all. Yep.
I have a question. This
Yes.
probably been asked from the beginning. I'm afraid I didn't come in from
That's
the
okay.
beginning. But I'm curious. I've been having issues with my hip, but it's like right here. So is that actually my hip?
Is it tender to touch when you press on it?
Yes.
So I'm gonna here, and it's very tender. Hip arthritis doesn't hurt to touch because the hip joint is so deep inside the body. But something like that, when you have pain out here and it hurts to sleep on that side, or a doctor comes up behind you and pokes you like that and you nearly jump to the ceiling, that's usually something called bursitis. Bursitis, here, I'll pull up a picture. It's, yeah. So, oh, that's not terribly helpful.
Oh yeah. I'm gonna research it when I get home then.
There we go. So this is actually pretty important because a lot of patients that end up with hip replacement end up getting bursitis at some point. Probably about 1 in 4 end up with a little bout of bursitis. A bursa is a structure in your body that interposes between bone and things sliding around bone. This part of the hip joint is called the greater trochanter. And sliding across the greater trochanter are all these muscles and tendons and things. And in between those are what are called bursae, or bursas. The bursa is a potential space. It's almost like an empty water balloon. It's got 2 layers, and those 2 layers can slide on each other. And that way, when your muscles are moving up and down across the bone, they're not grinding and rubbing on the bone. The bursa is acting like a lubricant in between the 2. That structure sometimes gets inflamed, and that's usually a very tender to touch, superficial pain where it's right that you can point, you can stick your finger and say, right there, it hurts. That is usually a separate problem from arthritis, and that's easily treated with a steroid injection. I actually have given both my wife and my mother bursa shots in the last year. Both for my wife is complaining about, she's like, my hip hurts, And I'm like, don't say that. I don't want to hear, you can't have a bad hip. And finally, I was like, where is your hip hurting? She's like, it's out here. And I'm like, does it hurt to touch? She's like, yeah. And I'm like, oh, you've had bursitis. Why don't you just tell me? She's like, I've been telling you my hip hurts. I'm like, yeah, but that's not your hip, that's your bursa.
So you could have bursitis in your shoulder, or
Yes.
anywhere in your body where you've got the bursa.
Yes. People that work like on their hands and knees can get bursitis under their kneecap. There's a bursa there. It's called prepatellar bursitis. So, yeah.
You have bursitis, and can you have that all of a sudden where your hip just gives out on you too, or is that 2 separate things, or is that the bursitis?
The phenomenon of a leg giving out all of a sudden is very similar to, it's a reaction, it's a nerve reaction. When you touch a hot stove, we all know this, right? You pull your finger away before you feel the pain. Everybody familiar with that concept? Right? You pull your finger away, and it's not until after that that you actually feel the pain. Well, how'd you know to pull your finger away? The signal went from your finger. It didn't waste time going up to your brain because your brain's slow and it's got to bounce around, it's got to process, say, what does that feel like? What is that? Oh, is that burning sensation? It's burning sensation. All right, go over here so I can think about what a burning sensation means. You don't have time for that. So the signal went into your spinal cord. It just said, lot of pain. It goes into your spinal cord and it goes right back out to the muscles, and your muscles go, ugh. Same thing can happen with an arthritic knee and an arthritic hip, where instead of pulling away, the signal goes into your spinal cord, it comes right back out before you even really feel anything, and it says, instead of saying pulling away, it says let go of the quad muscle, and that's when your leg kind of buckles on you like that. So anybody that's had an arthritic knee or arthritic hip has probably experienced that before. That's generally what that is. And that could be from bursitis too, because that is a pain signal coming from your hip. So I don't think I've heard of many cases of that buckling phenomenon happening from bursitis, but it does stand to reason.
If I had a tear in the meniscus and I had it taken care of by you folks, and I recovered really quickly. You know, I couldn't wait to go back to work. I was so bored, and I went back after 2 weeks. But I did use like a cane.
Yeah.
I borrowed my mother's cane. She wasn't even needing it at the time, and I just used it just when I had to get up, because I basically worked at a desk.
Yeah.
But lately, now it's probably been 8 years or so, lately, like line dancing out here on the wooden floor, this floor out here, you can't tell if you're looking, but if you're dancing, you can tell they've got speed bumps. And if you're on a certain speed bump spot and you're trying to like do a certain dance step, I popped my knee out last week. So I ended up, it was like the second or third dance, I just sit.
Yeah.
So I put ice on it, and it helped. And I also got that biofreeze that you rub on. But should I be concerned, like maybe I'm gonna need a total knee?
So my gut instinct, just based off your history, I saw you walk in, how you walked in, and just the story, most likely you have some degree of arthritis in your knee. It's probably at like a moderate state, so you're probably not at that level where you're grinding bone on bone. Part of arthritis is meniscus tearing. As the joint wears down, the meniscus starts to get ground away and it starts tearing, almost like hangnails. You like get a hangnail and it hurts, you pluck it. The same sort of thing can happen on the meniscus inside your knee. So oftentimes people come to me and they come and they say, well, MRI said I have a meniscus tear, and I'm like, you have end-stage arthritis. Like, of course you've got a meniscus. The whole thing is torn. The fact that you previously had a meniscus problem and had to have it operated on, that's probably what's going on. You're probably developing like that moderate stage arthritis, and you're probably getting some what we call degenerative meniscus tearing. You bend your knee the wrong way, and it can kind of pull on the meniscus a little bit and tear a little bit of it, and that can really set you back for a few days. But generally, you keep moving, and this is part of what we were talking about earlier about like trying to maintain a high level of activity. You keep moving, and where that little hangnail was that tore off, it kind of grinds away, and then you're sort of back at it again.
So I'm not harming myself more by dancing.
Not at all. Not at all.
You made my day.
Good. I'm glad. Where's my clicker? Where's my keys? Oh, here it is. So another thing that is very different nowadays versus back in 2000, around that area before then, is modern wound care. Back in the day, we used to use staples. You used to get a big bulky dressing that'd fill up with blood the next day, and they'd change it every single day until it stopped draining. Well, we've kind of realized that we have a sterile environment in the OR. So if we can get that wound sealed up really nicely and we can put a sterile dressing on and let that dressing stay while the skin is healing, that's going to lower our risk for infection. That's going to decrease the chance that a bacteria from the outside world is going to get into the hip. So that's this right here. These are these modern dressings that we're using. There's different brands and different types. They all look pretty much the same, look like a Band-Aid. And then you got this super sticky stuff that's water resistant. You have that dressing on, you hop in the shower, let the water run right across. Are you wearing yours right now? Is it taken off yet?
2 times.
2 times. They had to change it?
Right.
Good, good. The dressing stays on until you come to see us in clinic. We don't want anyone else taking it off because there's no reason to. There's nothing for them to see under it. It's a surgical scar. Only person that needs to see it is either me or one of my PAs that was operating on you with me. We use Dermabond. We use absorbable sutures and skin glue. So the sutures are snaking under the skin, and then the skin glue covers the skin, so the dressing comes off, and then there's nothing to do. There's no staples to take out, no sutures to cut out. You just let it be, and it'll heal. We are now sending patients home. Every once in a while, someone comes in and says, my aunt went to rehab in 1995, and I want to go to rehab because she did great. No, you go home. The rehab facilities have the same drug-resistant bacteria that live on the walls of the hospitals. And people, we have found, do better in their own environment, sleeping in their own bed, in the hallways and rooms that they're familiar with and comfortable with, that they've navigated for the last 10, 15, 20, 30 years. It's your own bacterial environment. The bacteria lining the walls of your house are bacteria you've been living with. They know your body. They're not trying to invade. So we really, really, really try to get people to go home. And nowadays, it's about 98% of our patients going home, with just a very few exceptions going to rehab. That is the ideal way to go. And from discharge to home goes outpatient joint replacement. The only difference is, rather than spending the night at the hospital, you're spending the night at home. Now, that's not available for everybody. There are some patients that have major cardiac issues, and the cardiologist wants to look at them for 2 days after surgery to make sure everything. Yeah, there are some patients that just absolutely need a hospital stay afterwards. But for most people, the thing preventing you from going home same day is you not wanting to go home same day. And that's fine. If you want to spend the night in the hospital, spend the night. The nurses will wake you up all night, and the next morning you're really going to wish you had gone home. But for the most part, especially with hip replacement, the pain is relatively manageable. You're relatively functional. And people that go home after surgery tend to have higher satisfaction rates, less readmission, lower infection rates, overall better function. In terms of recovery, so the surgery takes about 45 minutes. Like we talked about, you get that sterile, about. Now that's from skin until like implants are in, and we're just about to start closing up. The time that you're in the operating room is probably about 2.5 hours, because there's a lot of time involved with getting you in there, anesthesia, positioning, prepping, draping, and then undoing all of that on the back end of the procedure. We got to undo everything once we're all done and closed up. But the actual surgical time itself, about 45 minutes. Usually the spine will last for about 3 to 4 hours, and we want you to get up walking relatively soon afterwards. Like we said, discharge home same day or the day after. Everyone goes home with some form of a blood thinner to prevent a blood clot, and you have your whole big, wide, multimodal pain regimen of all of the various medications that you're going to be taking during your recovery. Your first 2 weeks after a hip replacement, relax. Go on vacation. Not literally, but like, what are you doing in vacation mode? You're not doing nothing. Why? You don't need to do nothing. You're on vacation. Same with a hip replacement. Take it easy. Give yourself time. It's going to hurt a little bit, but that pain will get better. And then as you start feeling better, as you start feeling more ready and able to go, you start moving, you start increasing your activity level. You come back at 2 weeks. That's a visit with one of our PAs, usually the PA that was assisting me on your case. And they're taking off the dressing, making sure the wound is well healed. Any medication refills are needed at that point, can be taken care of. Went the anterior approach, like we said, no restrictions, no precautions. Do what you feel comfortable with, sleep how you feel comfortable, etc. You then see me, I keep having to click over here, at 6 weeks. We're getting an x-ray at that visit, making sure the implants are stayed exactly where we left them, making sure everything is looking good. We're checking on the muscle strength. Like I said, most people are walking in pretty normally at that point. Sometimes at the 6-week visit, someone's still limping a fair bit and they're still struggling. And that patient might need a little bit of physical therapy. Patients get physical therapy after surgery, but oftentimes, especially when you come to our physical therapy after an anterior hip replacement, you see them for 2 or 3 visits and they say, you don't really need us. Like, come back later if you end up weak or something. But for the most part, people can kind of bounce back on their own. most patients at this point are about 75% better. That last 25% can go all the way out to a year. This curve over here is really how the recovery goes. It's really fast to start, and then those last couple of things that may bug you or bother you every once in a while, they slowly work their way out over time. Takes a full year for your maximum improvement. That's when you stop. So I say it's a year-long healing process. That doesn't mean it's a year before you get better. You just keep getting better and better and better and better over the course of a year. Not terribly relevant for you guys, but it does kind of help get a sense of what your level of activity and function can be, thinking about, returning to work. Generally, if you're doing a desk job, you can go back at 2 weeks. No one working at a desk job does go back at 2 weeks because they all have 6 weeks of paid leave and they're taking advantage of it, which is great. But if you really were dying to go back to it, you go back to it at 2 weeks. You're doing a lot of walking, you have to go up and down stairs multiple times a day. It's probably more realistic to say about 6 weeks. And if you're up on the girders, lifting heavy stuff and using equipment, like that's closer to 3 months. Brief recap, we talked about arthritis, various non-operative treatments, different aspects of surgery, how surgery's evolved over time, and then what exactly you would expect to experience after a hip replacement. In conclusion, hip replacement's a great surgery. It's made even better with modern day technology. Thank you. Thank you guys very much. That's my wife and I in Utah in our fellowship year, and that was our wedding about a year ago. Yeah. Any other questions? I know we're just about out of time.
What is your name?
Dr. Brothers. Alex Brothers. Brothers. Opposite of sisters.
Thank you for answering my question.
Of course, my pleasure. All righty.
You're good.